your questions.
Dave Gutierrez with NBC News. You mentioned that you had a plasma transfusion. Who donated that plasma?
Yes, so there was a convalescent sera transfusion that was provided, and that was provided by one of the patients who had recovered from Ebola previously.
From a contagious standpoint, when a patient comes in with this severe of a state, is it more of a risk to the health workers, or is it about the same as it would be at the early stages when you catch a patient with Ebola or if the previous patient was there?
In general, the more advanced a patient is, the more hazardous they are, the greater the amount of virus they have in their blood. So a patient who arrives like this in an advanced state requires extra care because of the fact that they're likely to be more contagious than someone in the early stages.
Doctors, knowing what you know now, do you think Dr. Salia should have been transported in the first place on Saturday?
I can't, that's up to the individual. There was physicians on the ground and physicians in the transport plane that assess him and make that decision.
How soon after Salia arrived were drugs administered?
I'm sorry?
How soon after Dr. Salia arrived were drugs administered to him?
Well, you want to take that, Dan?
Well, the supportive medications that he needed were administered immediately. For the specific Ebola treatment medications, I'm going to have Dr. Cradaville address that.
Yes, certainly. So we were able to pre-position both the Z-map as well as the convalescent plasma here, since we did have some advance warning that he would be transferred. So really, once we had the lines and were able to initiate the convalescent plasma, and then later on Saturday, we're able to initiate the Z-map.
And how early on did you know you were receiving this patient?
We got word about 2 to 3 days ahead of time, so we were able to use that time to help obtain medications and get ourselves prepared.
Before he
given on transport in that ambulance?
In the air ambulance, says he had an IV, he got fluids.
What about the OFD ambulance?
Well, he continued to, he had the IV and fluids during this, but that was relatively short compared to the lengthy air transportation.
Before he was diagnosed with Ebola, there was a negative test that came back at first. Is there an issue in your mind maybe about the testing process?
I don't know the details of that test, but it's not uncommon for people tested very early in the course of illness to have a negative test. Presumably just they're infected but have not enough virus to be detected, and then people are retested on day 3 or 4 or 5 and they're positive. So I can't comment on the quality of the test, but I can say that that's not an unusual event.
Dr. Smith, what exactly is going to happen to the doctor's body now, and how will that be treated much differently compared to anybody else who will pass away?
Well, in general, because the body is contagious and is a source of potential spread of an extremely hazardous virus, public health generally mandates cremation. And after discussions with public health in this case, that will be what will happen.
Would it be an autopsy?
Autopsies are considered too hazardous.
Where is the body currently? Is it here on campus?
I'd rather not disclose that at the moment.
Doctor, each Ebola case, after each Ebola case, doctors have said that they try to learn something from each case. Obviously, this is very tragic, but what, if anything, have you learned after treating this case?
Well, this is the first case we've had that's required hemodialysis and respiratory support of a ventilator. So we had prepared for this ahead of time, even before we knew we were getting this particular patient. We practiced it, and things went very well. I guess we learned that. I think we also got some laboratory studies, such as how much virus he had in his blood, which we think will be very high. But these will be sent to the CDC. Different samples from this patient will be sent to the CDC, and when we get those back, we'll correlate it with how sick he was, how far into his illness. And he presented a number of days later in his illness than the first 2 patients we had. So a lot of the learning will occur after all the results are back.
But I will say it is a reminder of what a deadly virus it is and how important it is we continue to maintain a global response to address it.
Several of you discussed how this affected the staff. If you were to get another Ebola patient in the coming days, what do you say to your staff to rally them to prepare for that next patient?
Again, I think our staff, they're deeply saddened right now and grieving this loss. Because with all of our patients, you just develop a personal connection immediately. But I will say that this team, this is their mission. This is what they're committed to do. This is what they have been trained for. And though this experience has been incredibly difficult for them, if anything, I think it further solidifies how they want to continue to care for these patients and really provide the best level of care possible.
It's the first time an Ebola patient has died in your care. Do the doctors who are treating him feel defeated?
I certainly do not. I am very, very proud of the care that we provided. I know that we gave him every possible chance to survive. I think that his family feels confident in that as well, which is more important than how we feel. Mostly I'm proud of the nursing staff and the respiratory therapy staff, because we sit here, but they're actually the most courageous ones because they're in the room all the time, 24/7. So that's really where the most intense courage is, I think, on our team. And I don't think we do feel defeated. We are going to analyze this. We're going to learn from it. We're going to figure out how we can do better with every single case. But I don't think immediately as we look back that there's any key issue that we could say we should have done differently.
You know why it took so long for them to decide to transport Dr. Salia? He was diagnosed on Monday, is that right? And then he wasn't transported until Saturday?
I don't know the details of what went on over there.
Why don't we take one question or two from the phone line? There are a number of people, I believe, that are queued up. Please go ahead on the phone.
Where did the ZMAP come from?
Yeah, the sponsor was able to provide that to us. So they reached out to us and said that they did have some product available. And so we promptly had an institutional review board, an IRB, which provides oversight for human subjects protection here, meet to discuss it. They approved the use, and it was shipped and made available by the time the patient arrived.
When you say it was from the sponsor, then what does that mean exactly?
Yeah, so MAP Pharmaceuticals, which developed the medication, was able to provide that and send it to us.
Hi.
Okay.
Do we have any more details on, hello?
Yes, please
Hello?
go ahead.
On the inoculation, the incubation period, it's not clear how he contracted the virus beyond the 21-day period.
Yeah, there was some discussion about an earlier exposure and putting himself in quarantine, but he passed, as I understand it, the 21-day period. So one would have to assume that it was not from that initial exposure, but from a later one. He was a surgeon, and even though he did not work in a specific Ebola hospital, he worked in an area where there was a lot of Ebola disease, much of it probably unrecognized, and there were many opportunities for him to have contracted it.
And do you know the timeline from the first test to when he arrived? His earlier test was on what date?
I believe his first test was on November 7th, and the confirmatory test November 10th, and he arrived here on day 13 of his illness.
Okay.
Do you think there's a certain time frame where if you catch it up to a certain day, you have a better chance of curing it?
Well, I think the supportive care, the earlier you start supportive care, the better. Undoubtedly, there are differences from one case to another in terms of the response to infection, depending on age and other factors. And so not two people inoculated with the same virus at the same time will not necessarily react the same. But as with any other infection or any other disease, the earlier the better, of course.
Is there a certain level of frustration from your staff, thinking that if he had arrived here sooner, you might have been able to do more for him?
I don't know that I would say frustration. I think, the sooner the better in these circumstances is always sort of the rule of thumb. But no, frustration wouldn't be the way I would categorize. I think the staff, to Dr. Johnson's point, gave it everything and then some, and that was their focal point. And now I think they need a little time to grieve and really find peace within themselves, awaiting our next patient.
I want to add to that and to what Dr. Johnson very nicely stated, that as physicians and nurses, we want to cure every patient we take care of, but all of us deal with very critically ill people with and without Ebola, and some patients die. And every physician that I know and respect always takes that to heart. They go home and they think about it and worry about it, even if there's nothing you would have done differently. And so this case is like that, but it certainly does not mean we're going to give up our mission.
Yeah, I think the
Staffers that work directly on him as far as the next 21 days, will they be on a self-isolation or what is your protocol?
We have basically not I don't know if self-isolation, but a self-monitoring program. We've worked out in conjunction with Douglas County Health Department, so everybody takes twice a day temperature and twice a day and once a day symptom check, and they log this into an electronic database that we followed every day. So those of us who run the unit will check every employee's data every day, and if someone has a temperature or a cold, of course this is flu season and there are people going to get flu, they're going to get sinus infections, urinary tract infections, we're used to seeking them out quickly if they have any symptoms, evaluating that and making an assessment.
Will they all have to continue to work in that time?
Yes, as long as they're asymptomatic, they're considered safe. Even if they were infected, they would not spread it to anyone else.
If they haven't been exposed but haven't shown any symptoms yet, how does the Ebola virus thrive in these colder temperatures? I mean, all the other instances have been in Africa. Does the temperature have any effect on its viability of, infecting someone?
It might in the external environment. I don't know if any Ebola viruses would do very well in our Omaha winter, but I will say that once inside the body, they're able to thrive as other different types of viruses are.
Let's try a few more questions from the phone, please.
Yes, I have a question. How long does it take for the virus to show up in the blood?
Well, from the time of infection to the time of the first symptom is a number of days, maybe 7 days. There is a little bit of variability from person to person. And then you start to get fever, and if you check right then, often you'll get what you call false negative. In other words, the virus is in your system, but there's not enough to be picked up by the test. And usually you have fever for 3 to 4 days, and then you start getting other symptoms like diarrhea, nausea, vomiting. And so by that time, you're up to about day 11 after inoculation. And at that point, the tests are almost always positive.
Another question on the phone?
Can I ask a question, actually? Can you say who donated the plasma for the plasma transfusion?
No, we don't disclose the name of the individuals, but suffice it to say it was someone who had survived an Ebola infection. Again, we don't say who has donated the plasma.
Were there any additional protective measures taken by the staff in terms of biocontainment gear, that type of thing, from when the second patient was treated here at the med center to where this third patient was being brought in, since he was so much more sicker?
Well, we have a range of gear that we adjust depending on the condition of the patient. Because this patient was advanced and there was concern about body fluid control, we did use PAPRs initially and then back down. So the exact type of respiration equipment varies a little bit, but they're really fairly similar. We adjust as we go along. After we get the patient in the bed and assessed, then we modified it very slightly from the first shift to the second shift, depending on what we found.
Can you say what a PAPR is?
It's our positive air purifying respirator.
You said the body's going to be cremated. Is any of his blood going to be used for testing?
Well, certainly one of the things that we do is, obviously as a part of the normal care of the patient, we do collect blood samples. So some of the blood will continue to be evaluated to look at viral load and things like that.
Doctor, describe for me what you mean by viral load.
Yeah, so the viral load is really just how much virus is contained in the blood.
Did you do that testing here, or is that sent to CDC?
That's sent to the CDC. It has to be a level 4 lab.
Any other questions on the phone?
Yeah, I have one quick question. I wanted to ask, why do you think some patients seem to get more severe versions of this disease than others?
I think that has to do with a number of factors. It might have to do with host immune status, perhaps with age, perhaps with the amount of virus that you get inoculated with. We know this from some other infections. Virtually every infection has some different presentations than others, so there might be a case of food poisoning at a picnic, and people will get different amounts of gastroenteritis depending on their immunity and how much they're exposed to. As far as the details on that, we don't understand very much about Ebola. There's a real need for more information.
Is the strain of virus that Dr. Salia had the same as the other patients who had?
We assume it's the Ebola Zaire, but we don't know that yet.
Any other questions?
Hi, I have a question.
Sure.
Hello, I have a question. I believe it was reported that his wife said she tested twice negative for Ebola. Do you have any information on whether he was negative, and if so, if it was more than once?
No, I don't have information on that particular question.
As to whether he may have transferred his virus before knowing if anyone else has been infected since he had Ebola?
No, we did get some limited records from Africa, but we don't have the details of movement or contact.
Some people have described Sierra Leone as kind of the eye of the Ebola storm right now, with so many people getting sick there and conditions being so severe. If or what, or can you describe your outreach from your team here to the doctors there in Sierra Leone? What kind of contact do you have with them in helping them with your research?
Oh, we have several contacts. There was, in fact, a phone conference this morning with some people who are working at the new 25-bed hospital that's been built by the U.S. for Liberian healthcare workers. With one of our earlier patients from Liberia, who knew the physicians over there very well and knew how to get in touch with them. We did have actual live phone conversations and shared information. Thirdly, our first patient was a physician who'd worked over there, and he taught us a lot. As we talked about, Dr. Sakra taught us a lot about what conditions were like and how they dealt with Ebola in different settings, because they deal with a large number of patients. And so there are many opportunities for us to interact with physicians in Africa, and we hope that our experiences cumulatively will provide some useful information for them.
I remember you said you were in contact with doctors in Liberia when Dr. Sager was here, but I'm sorry, I just want to make sure I understood. Are you in contact with doctors specifically in Sierra Leone, or just in general, in those 3 countries in the region?
We reached out to them. We tried to reach them by telephone and by email, and we couldn't get through, but we did attempt.
And additionally, one of the things that many of you may have heard of is that we've had a very active initiative of education. So one of the things that the team has done is put many of these materials on the website and also through the Apple iTunes University account. So really what we're trying to do is we do find information and develop resources. We make those as widely available as possible.
Why ZMAP instead of TKM or the how do you pronounce it?
Yeah, so there's certainly many research interventions that are potentially available, and ZMAP is one which has some very robust animal data. So it seemed to be something that would have a potential benefit for the patient, and so we were able to obtain access to that, and then we discussed it with the patient's wife and the patient's son, and they did agree to a course of that.
Any other questions? Maybe one more from the phone, please.
Hello. Speaking of the ZMAP, Did you notice any reaction to it? Dr. Brantley, he was given it, his condition improved.
Yeah, I would say that, as you've heard, the patient was very critically ill, and the ZMapp was well tolerated, but I'd say that it's difficult to assess that there was whether there was a significant clinical change or not.
Is there a question in the back?
In terms of the medical waste for this patient, since his case was much more advanced, how did that compare to the prior two patients and the biocontainment staff has to do with
They dealt with it appropriately. The biggest jump in waste volume was between excuse me, the first patient and the second patient, because we established a small laboratory in the unit, and they also wore protective equipment, so that added to our waste volume, although it was handled very well. And the current patient had a fairly brisk waste volume, but it was not there long enough to generate the total amount of poundage that we had before.
Just to clarify, you touched on it. Are you guys in any way involved with his body at this point, or are you trying to go to the Department of Health for the
We're not directly involved, but other people are along the line are making the arrangements.
What time frame will it be before cremation?
I'd rather not say that, just for the family has asked that we have privacy in that regard.
It seems like a lot of what you're talking about is the importance of early treatment. Do you think there's anything more that you've learned, that could be done to help treat patients earlier and make sure they get treatment? I mean, there's more that can be done to get them to the States sooner? Is there more that can be done in Africa, in the outbreak zone? Do you have any thoughts on, how to get these patients treated sooner?
Well, I think, as Dr. Cradaville mentioned, people have tried different antivirals, but no matter which antiviral you try, every patient needs aggressive rehydration, because one of the major causes of death in this illness is fluid loss due to volume depletion from diarrhea and vomiting. And the experiences we have and others have had suggest that earlier you start getting fluid in, the better. Now, a number of treatment centers in Africa do not have the benefit of IV fluids that we do. And so it would be nice if in the area over there you could promptly get people plugged into IVs and replace the fluid, but that's logistically difficult. I know they're working on that at the present time.
Any other questions?
Please mute your phones.
How did that compare to the other two patients
Well, the others were day 6 and day 8 of starting from symptoms.
Okay. Well, thank you very much. We particularly appreciate the respect that's been shown by the media to the family and to our staff. As you've heard, the commitment remains unwavering. The challenges are truly global, and this is what great academic medical centers in the United States do, as we rise to those challenges. Thank you so much for being with us this morning, and again, we very much appreciate all the respect that you've shown for our staff and to this wonderful family. And my personal thanks to not only those seated here, but those who have spent the last 36 hours working really, really hard to try to change the outcome. Thank you very much.